Hello guys, thank you again for tuning in to Amanda's show. My name is Amanda Pozenzi. I'm glad to be your host again for today. Today we are going to have a special guest, a doctor in the house. Not just a doctor, but a gynecologist. In this waiting season, we have health issues, and so we are going to tackle them, and he's going to talk about infertility. Yes, thank you. So, Daktari,
Yes.
karibu sana.
Thanks, Amanda. Thanks for coming.
Thank you. Can you introduce yourself?
Okay. So my name is Mr. Chris Obwaka. I'm a board-certified consultant obstetrician gynecologist. Recently back from global travels, so I was away for 3.5 years. I've been back maybe 3 months now, and happy to be home.
Welcome.
Yeah.
Karibu tena.
Asante.
Yes. So, in this office, you treat so many patients,
Yes.
and who have different conditions.
Yes.
Yeah, but most of them, the current issue in health is about infertility. So I would want to know, if someone hears infertility, what comes into the mind? What should ring in their mind?
Okay. So fertility is the ability to have a child. When we speak of infertility, then now it's inability to have a child, so infertility. Some schools of thought are moving away from terming it infertility because there's a permanence to it or a finality to infertility. You're unable to have a child. So mostly we're using subfertility now. So subfertility means that there's problems having a child, but we can't predict the future. So we can always say there's always hope. Subfertility is defined nowadays maybe according to age. So if you're above the age of 35 and you've been trying for a year, so trying we mean same partner, regular intercourse with no contraception, and you've not been able to conceive within a year of trying, then we'd say you have a fertility concern. If you're above the age of 35, usually we cap it at 6 months. So if you've been trying regularly, say you're 38 years old, you've been trying regularly for 6 months, and nothing is happening, then at that point is when we'd start the fertility investigations.
Okay. And so, what is this? There are so many. The problem of periods, like irregularities of periods, can that also cause infertility?
Yes. So with irregular periods are a symptom.
Yes.
So they're a symptom of different conditions, and those conditions are what cause infertility. So it's not just irregular periods. So commonly is things like polycystic ovarian syndrome, whereby your ovaries are not producing hormones properly, they're not producing eggs properly, your hormones are out of balance, and you're not able to ovulate, and you're not able to conceive. I think to understand the whole fertility thing is just to look at the whole chain, call it like the chain of fertility. So for you to be able to conceive, it takes two to tango. Yes. So there's the man's part to role to play. You need to the ladies' part. Yes. Of course, in our clinic, we mostly get the ladies here.
Yeah.
Very rarely they can drag their husband to the clinic with them. But from the man's point of view, then there's the sperm count, for example, and how the sperm function, how they swim, whether there's infection, so that can contribute to infertility or subfertility. From the lady's side, we need your ovaries to be functioning well to produce hormones. We need the ovaries to be functioning well to produce eggs as well. And then we need your tubes to be open so that the healthy sperm and the healthy egg can meet.
Okay.
Then once they meet, we need a womb which is receptive to the embryo, to the fertilized egg. So if you have a problem at any point along that, then you can have problem with fertility. So when you talk about hormonal balance, that's a function of the ovary. But also a function of you produce hormones from many different parts of your body. Yeah. So you produce hormones from your thyroid. If you have a thyroid problem, can give you infertility. Yes. You produce hormones from just above your kidneys. They're called the adrenal glands. So things like cortisol. If you have problems with that, you can have infertility. You produce hormones from your brain. There's glands in your brain, like the pituitary gland. So you produce hormones from so many different places in your body, but they all talk together and they all act in concert to be able to give you regular periods, to give you regular ovulation, to give you fertility.
Okay.
Yeah.
And what is the most causes of ovaries blockage? Because nowadays you might hear someone has a ovary blockage.
So typical, not ovary blockage, usually be tubal blockage. So the main causes of the tubes being blocked, either you've had a previous pelvic infection, like something called PID, pelvic inflammatory disease. You've previously had an ectopic pregnancy, so the tube is damaged. You can have blocked tubes because of other things that are pressing you from outside, like big fibroids. You can have, if you've had previous surgery, like many cesarean sections, you've had a myomectomy, the past removal of fibroids, you have lots of scar tissue in your tummy, then all that can cause the tubes to be blocked. But in our setting, infection is typically the commonest cause of blocked tubes.
Okay.
Yeah.
Talking about fibroids, they are so they are so common in Africa.
Yes.
Let me say in Africa.
Yeah.
Yeah. What is the cause? Why is it? And then you don't even you can't differentiate the age. Like you find someone, whether they have been on contraceptives or not, or you just find people having fibroids. What is the cause?
So, like many things in medicine, we don't know the actual cause of fibroids, but what we know is risk factors. Okay. Like if you have this set of risk factors, then you're more likely. It doesn't mean, so you see, like for example, like malaria, we can say if you're bitten by a mosquito that is carrying the parasite, then you're more likely to get it. But there are people with risk factors. It is, you can have all the risk factors and not get fibroids. Yes. Someone can have one risk factor and get. So when we talk about the risk factors for us in our setting, the most the most obvious risk factor is our race. Because you're a black woman, then you're already, just by that only, you're more likely to get fibroids than a Caucasian or an Asian lady. If your family history of fibroids, say your mom has had big fibroids, your sister has fibroids, then you're also at risk. So just be on notice.
It can be genetic.
It is, there is genetic component to it. Okay. And then there's also issues to do with estrogen exposure. So if you started your periods very early, or you go into menopause late, or you've not had any children, or you've had a big gap in between your children, then all those are risk factors for fibroids. Diet comes into play as well. So people who eat a lot of processed foods, who eat a lot of trans fats, so the bad fats, ultra processed sugars, things like that. So if you're eating KFC every day, if you're putting 5 scoops of sugar in your tea, then you're at high risk. So when we look at and then of course lifestyle issues like smoking, drinking, not exercising, being obese and things like that, overweight. So there's all those risk factors. We don't know the actual cause, but we know that this set of things are the ones which are being found in people with fibroids.
Yeah. Oh, okay. So people should stop eating KFC.
Not every day.
Are you hearing?
I just tell my patients, like, I don't want to give you something that will feel like a prison sentence to you. So my message is usually enjoy life, because life is unpredictable. Yeah, I've seen people who have left. Though you leave your house and say, "Tonana Johnny, I'll see you in the evening," but who tells you come home? Yeah. So enjoy life, but do it in moderation.
Yeah, true. Yeah. And then there is also miscarriages a lot that can be caused by those fibroids or other sicknesses. Yes. What are the most causes of miscarriages? And maybe repeated, because one can have more than one miscarriage. Yeah.
So with miscarriages, we define it as any pregnancy loss before the pregnancy is viable. So viability, the age of viability differs according to like the country and the quality of the healthcare system. Mm-hmm. So like in Kenya, we would say maybe between 26 and 28 weeks. If a baby is born at 28 weeks, then they can survive. In some countries, even as early as 24 weeks. So if you lose a pregnancy before, say, 24, 26 weeks, then we call it a miscarriage. Yeah. Most of the miscarriages will happen in the first trimester, so the first 12 weeks is the most precarious time. Miscarriages are very, very common. About 1 in 4 women will have one or the other form of miscarriage in their lives. Recurrent miscarriages, on the other hand, are not as common. Recurrent miscarriage, we define it as 3 or more consecutive pregnancy losses. So maybe even you don't have any children. You get pregnant, you lose this, you lose the next, you lose the next. That's when it's called recurrent. It's 3 or more. The most common cause of miscarriages is chromosomal or genetic problems. So the pregnancy was just not normal from the very formation of it. So what the body does is, the body has its own mechanisms to sense when things are not growing correctly. So you will be pregnant, you get a positive pregnancy test, and then maybe you do a scan and you find it's an empty sac. Or you do a scan and you find there's an embryo but there's no heartbeat. So the body sends signals to stop the development of something that it doesn't perceive as developing normal, like it has genetic problems. And then aside from the commonness is chromosomal, so like 60-70% is genetic problems that we have no control over. And then other things is now, like you mentioned, things fibroids. If you have any abnormality of the shape of your womb, some people like have a heart-shaped womb, some people have half a womb, some people have 2 wombs and 2 cervixes. So there's all these things that you can be born with. Yeah. It's called a biconate uterus. So you can have a pregnancy this side and a pregnancy on the other side.
And they're
at
twins.
the same time. Yes, they're twins.
And they come out the same time.
Yes, but we try to bring them out at the same time.
Hey, okay.
There's issues with the infections as well. So we talked about infections before. So like sexual transmitted infections, uncontrolled HIV, medical conditions like if you have severe like uncontrolled diabetes, severe liver disease, kidney disease, things like alcohol, smoking, illicit drugs. So there's a whole plethora of things that can cause miscarriages. But typically I say it is very common, it's unlikely to be recurrent, and most of the time you have no control over it. Because people come and blame themselves. Yeah.
So for the chromosomal issues, so there's no medication that one can take?
No. So with chromosomal issues, the key is in prevention. So if you find you've had recurrent pregnancy losses, then we do chromosomal studies. So for example, if you go for a procedure, like an evacuation procedure for a miscarriage, maybe a 3rd miscarriage, then we'll take the pregnancy tissue, send it to the lab. So they try and find out what is the genetic problem here. If they find a genetic problem, then we'll test mom, we'll test dad as well, and find if it's something that the combination of the two is leading to chromosomal abnormalities. I think in some countries, in developed countries, some people do genetic testing even before marriage.
Yes.
You know, here it's just
let's go
and visit the relatives to Salamiane, Rurashio, all those things. But other places they'll do like medical checkups before you get pregnant. So we know HIV status, hepatitis B, syphilis, whether you're fertile, like fertility tests, whether you have any genetic problems that me and you mixing will give our children problems. So, but we don't have the capacity or probably even the finances to do it. It's quite expensive to do genetic testing.
Wow. And what about the non-progressive pregnancies?
Yeah, so those are there's two main types when you say non-progressive. So there's something called a blighted ovum. It used to be called blighted ovum. That's what people know it as. It's called anembryonic pregnancy. So it's when the sac forms, but nothing forms in the sac. So that's not a pregnancy that can continue. Again, chromosomal problems very early. Then the other is called a missed miscarriage, whereby you're pregnant, there's an embryo, you pick up a heartbeat, say, at 5 weeks, 6 weeks, and then you do another scan maybe at 9 weeks and there's no heartbeat anymore. So the heart stopped beating at some point, maybe because of, again, it didn't develop properly. So with non-progressing pregnancies, again, we don't know the cause, but more of them are related to genetic problems.
And is it the same, the non-progressive, is it the same like the one that doesn't go into the uterus?
No, so that is a type. We don't really classify it as a miscarriage, but by definition it is, because it's a pregnancy that would go to viability.
Exactly.
So what you described is an ectopic pregnancy. So with an ectopic pregnancy, the embryo attaches in the tube. The tube is very thin, like very thin straw to semen, and only has certain elastic limits that it can go until. So as the pregnancy starts growing, maybe 5, 6, 7 weeks, and then it reaches its maximum expansivity, if that's a word, and then you get what's called rupture of an ectopic. That's when now you have the severe pain, you have internal bleeding, and that's now a gynecological emergency.
So they have to operate on you? Or
Yes.
They have to...
So once it's ruptured, then the only treatment is surgery, whereby most of the time the tube is damaged and we take up the tube on one side, the side that has the ectopic. If we pick it up earlier, so you can see it even before it ruptures, like if you do a good scan.
Yeah.
Sometimes you can even see the embryo in the tube with a heartbeat. So you pick it up earlier, there's options for either conservative management, which is watch and wait, or there's specific medication. We can give you injections to try and dissolve the pregnancy so that you save your tube. Yeah, so I think the main thing is, if you get pregnant and you have any of the risk factors for ectopic, you should see your gynecologist early for an early scan. So at least from the beginning, tunajua, we know it's in the right place, it's growing normally, there's a heartbeat, it's viable, then we can start the pregnancy journey.
Some people who have issues with irregularities of period, they might get pregnant and not know.
Yes.
So when now, how will they be able to detect that they are pregnant, and or it's just the periods that have not come?
So we said the most common cause of lack of periods is pregnancy. That's the most common cause. So even if you have irregular periods, and then now your periods imepotea maybe for 8 weeks, and you're having a bit of nausea, your breasts are a bit tender, having a bit of bloating, you're sweating, and you don't know why.
Sometimes you might not realize all those symptoms, or you might not even have them. So how would you tell that woman
to test?
Maybe.
So for those ones, we may pick them up a bit later, like when now she's having a small bump, then she realizes something different. Most people have some symptoms of pregnancy. It doesn't have to be the full-blown kutapika, vomiting. Am I speaking Swahili actually?
Yes, that's okay.
So some people don't have the full-blown, the typical kutapika and nausea and all that. Some people just have tender breasts. Some people just have bloating. Some people just have reduced appetite. But it goes back to the thing of, if you're having menstrual irregularities, you should be seen. So that we can find out what's the cause and we can sort it out. So that it's not a guessing game like this month I was pregnant. And then of course there's the other aspect of contraception as well. So if you're sexually active, you're in your childbearing age group, and you're not on contraception, it's only a matter of time.
You'll be bearing fruit.
We'll be bearing fruit. We don't complain. It's what's paying the bills.
Talking about contraceptives, are they factors that contribute nowadays into infertility?
No. So I think that's one of the biggest. I get lots of questions about it. Or will this give me infertility? So all the modern contraceptives have not been associated with infertility. I think the two things, one is the older ones like Depo, the ile shindano. The older method has been associated with problems with conceiving, because what it does, for some people, it makes your periods disappear. And even when you stop getting the injections, your periods can disappear for 1 year, 2 years. And in that time, if you're not having periods, most likely you're not ovulating. If you're not ovulating, you can't conceive. So Depo, people are moving away from it. Some people are die-hard Depo, like my older patients, my older clients, they're die-hard Depo fans. But most young people, in fact, I can't tell you the last time I gave a younger person the Depo injection. And then the other thing with contraception, when you're in contraception, then you're not using barrier methods like condoms. So it also predisposes you, if you have like a risky sexual lifestyle, so to speak, then it predisposes you to infections. Get infections, then can get your tubes to get blocked. So that's the only way I would say the linkage between contraception and infertility. The older method and predisposure to infections if you're not careful. But the contraceptives themselves, like the pills, the patches, the coils, the implants, none of them cause infertility.
But they can cause hormonal imbalance.
Yes. And the hormonal ones, yes.
The hormonal ones. They can cause hormonal imbalance.
Yes.
And then the hormonal imbalance causes...
So the hormonal imbalance for contraceptive is transient. It's when you're using it.
Okay.
So if you're using the pill, maybe you can get hormonal imbalance at that time that you're using it because they are hormonal. But when you stop the pill, then your body tends to reset within 1 to 3 months for most people. So it wouldn't give you a year of trying anyway. So once you stop the hormonal contraceptives, your body resets.
Okay.
Yeah.
But why would people prefer hormonal, yet it plays a big role
because of options.
Yeah.
Options are limited. So first of all, we won't even go into male contraceptives because I get that a lot of flack online, like why aren't there contraceptives for men? It's us women who have to deal with all this stress. So with contraceptives, let's say female contraception, because that's the field I'm in.
Yeah.
The two big groups are hormonal or non-hormonal. If you want non-hormonal long term, there's only one option. It's a copper coil.
Yes.
Everything else is hormonal. So it's people will choose hormonal because of lack of choice. So some people don't want like a procedure to insert the coil into your womb and have some foreign thing in your body, that kind of thing. So if you don't want the coil, then you have to now look at the hormonal methods. It's lack of choice.
You say that some people can miss periods for some time, and when you miss periods, there is no ovulation. But how come women sometimes we get pregnant when our menses have not come back?
Okay, so
after childbirth,
like generally speaking, we use regular periods as it's called a surrogate marker for ovulation. So if you're having regular periods, normal flow, not very painful, quite likely you're ovulating.
Okay.
However, we know that even like you've delivered, you can get pregnant even before your first period comes back.
Yes.
So you can ovulate without periods, but it's not the norm. It's the exception rather than the rule. So the rule is more like if you're regularly menstruating, then we can say that probably you're ovulating as well. So it can happen. You can conceive without periods.
Yes.
But it's not common.
Okay.
Yeah. But you see this, like we say, diseases don't follow textbooks or medical conditions. So the textbooks will say that if you're not menstruating regularly, you're not ovulating. But there's always the outliers in medicine.
Okay. So what are the methods of conceiving? Because nowadays there is more than one.
Yes.
The normal one that we know, the natural.
Yeah.
So I know there are so many ways of conceiving.
Yeah.
What are those?
So maybe I'll broaden it, not just like ways of conceiving, but ways of having a child.
Yes.
So we'll start from like the rarer ones, which is like adoption, which is a big thing now.
Okay.
And then surrogacy has gained momentum in Nairobi as well.
Really?
Yeah. So we have lots of surrogates here.
Kenya is becoming a Europe.
Yeah, it is. I mean, we have lots of couples who for one reason or the other are unable to have a child, or one partner is unable to contribute to conception. So, for example, if it's a lady and she can't carry a pregnancy for any reason, then you can have a surrogate carry your biological child, and then after delivery, then basically they adopt. The commissioning parents adopt the baby. And the surrogate parent, surrogate mom, then she gives up rights to the child. So there is adoption, there's surrogacy, and then the other two big groups is either natural conception. So natural conception is you're not using any fertility medications, you're not getting any injections to cause you to ovulate more. You have regular intercourse with your partner, and you just conceive naturally.
Yeah.
So for a great majority of the people, within a year, about 95% of people, as long as you're fertile, you're healthy, you're below the age of 35, 95% of people will conceive within a year. That's why when people come after 4 months, and we try for 4 months, not yet. It's not yet time to panic.
You have a year.
You have a whole year. And then if you add another year on top of that, in 2 years, 98% of people will conceive. Yeah. So you see that the typical definition of subfertility is a small group of people, but of course it causes untold misery. So you can do natural conception, and most people will conceive spontaneously. And then there's assisted reproduction, or IVF is what people mostly know. But even in IVF, there's different procedures for IVF. So there's stuff like intrauterine insemination, whereby maybe if the sperm count is low, they can get the sperm, they do what's called sperm washing and concentrate them, and then the sperm is now, when the lady is ovulating, and the sperm is put artificially into the womb, and that can happen like that. So IUI, intrauterine insemination, and then you can have the proper IVF, whereby we stimulate your ovaries to produce eggs. You get the eggs, you get your partner's sperm. It's all mixed in the lab, and the embryo is growing either day 3 or day 5. And then they take the embryo and implant it into your womb for you to carry the pregnancy. So in vitro means in glass. So IVF is fertilization in glass, like in the lab, in a petri dish. That's why it's called IVF. Yeah. So in vitro is this baby is fertilized in glass, on a petri dish. Yeah. So there's even for in IVF, and there's lots of different combinations of techniques to do it. But yeah, broadly speaking, it's either natural conception or assisted reproduction, which involves many different things.
But still, if you have any problem with maybe the fibroids or cyst, what is the difference between cyst and fibroids?
So cyst is a growth so if you look at the womb has 3 layers. So there's the inner layer, which you shed every month as a period.
Yes.
Then you have a muscle layer, which gives you the cramps during the period, or what gives you the contractions during labor. Then you have an outer layer. So fibroids is an overgrowth of the muscle layer. So you get like muscular growths. They look like balls, rubber balls. If you look at them on scan after surgery, they look like white rubber balls. So it's a benign condition, it's not cancerous, but can give you heavy periods, can give you painful periods, can give you infertility. Cysts, on the other hand, are like fluid-filled sacs in the ovary, and for us to say it's a cyst, it has to be more than 3 centimeters. So you can have cysts which are benign, they're called simple cysts. You can have cysts which are cancerous as well. Yeah,
so the cysts can be cancerous, but the fibroids can...
Fibroids are not cancerous, yeah, but cysts can be either benign or cancerous, depending on how they look and blood tests that we do. So there's ways we go. Once we see a cyst, then we say, is it a simple cyst? Is it a complex cyst? If it's a simple cyst, how big is it? Does it need anything doing? Or we repeat a scan in a few months. If it's a complex cyst, then we're more worried. Then we send you for specialized blood tests to tell us what your risk. So if you see a complex cyst and maybe the blood tests are very high, they're called tumor markers, then now we're thinking this is more towards a cancerous cyst than a benign cyst.
Okay.
Yeah.
So if you have all those, one of the conditions, and then they do the IVF, what are the chances of having the child? Or?
So we say before IVF, like optimizing for IVF includes treating any underlying causes that can be addressed before IVF. So say your tubes are infected and blocked and they're filled with fluid, then we'll take out the infected tubes, and that will increase the success rate of IVF. If your fibroids, which are growing in the inner lining of the womb where the baby is supposed to implant, we try and do surgery to take those out before IVF. If there's any blockage, so in your partner's, it's called the vas deferens, the tube that carries the sperm, and that can be addressed by a urologist, for example, and block them. So we just try to optimize you, make sure your eggs are of the best quality, your womb is in the best condition, your partner, and also your general health.
Yeah.
So for IVF, it can bypass some of those problems, but typically the success rate is higher if you address those things before. A big question I get is, what are my chances with IVF?
Yeah, I was coming there.
Yeah, the success rate of IVF, despite all our decades of advancement, is very low still. So like maybe I'll quote UK because that's where I've been working most recently. So the best you'd get in UK, you're below the age of 35 and you're otherwise completely healthy, is about 30%. 30% success rate. And the older you get, so if you get to maybe about 44%, 44 years and above, then your success rate is in the range of 2%, 5%, that kind of range. So the success rate is not very good compared to there are centers that will quote much higher success rates and say, in our center we have 60, 70%, but it depends on which metric you use.
Yeah.
So with IVF, you can get 60% of to conceive, to have a positive pregnancy test. But the real metric that matters is baby home.
Yeah.
How many of those pregnancies will continue to the end, delivery, healthy baby, go home with the baby. That's 30%. Yeah. So you have all this. wanachanganya watu na numbers. So if here 70%, but should ask 70%, what metric are you using? Is it just positive pregnancy test, or is it a continuing pregnancy to the end? Yeah. So 30% is not, it's not great.
Yeah.
But it's, go for IVF when you've exhausted all the options.
Okay. And do you perform them here?
No. So we have, nowadays, in the past it used to be one doctor is a jack of all trades. Now people specialize in different areas. So like for myself, it's ultrasonography and minimal access surgery, so laparoscopy. For other people, it's fertility. For other people, it's cancer care. Yeah. So we have partners, fertility partners that we work with. So when we get a patient who, maybe the couple has a problem conceiving, we do the initial testing to find the reason. Then once we find the reason and optimize them, we send them for IVF. IVF gets them pregnant and then sends them back to us at about 12 weeks for normal antenatal care. Yeah, so we don't do IVF here.
Okay. Yeah. What are these? Some people can go to the doctors and they're told everything is okay. They have no problem.
Yes. The most frustrating thing. Yeah.
How do you handle that situation?
So it's called unexplained infertility, also because our medical knowledge is still evolving. There's so many things I think we've just scratched the surface of medicine.
Yeah.
Like there's so many things about how the body works and what causes diseases, what causes different conditions that we don't know. So like the limit of our investigations, we do everything we know. Then when we reach the end of our line, then we call it unexplained infertility. You're not conceiving, but I can't tell you why. They're not fine, but we don't know why.
Okay.
Yeah, but a lot of those people still, even if you do nothing, in a few years they conceive spontaneously. So there may have been something that just, maybe your body corrected itself, or you changed something in your lifestyle, your diet, stress reduction, and you just conceived on your own. Yeah. So it's very frustrating, the unexplained. People like to know.
Yeah.
So I'd like to know, tell me my tubes are blocked, and so that we can do something about it. But if you tell me everything is perfect, your sperm count is perfect, you're ovulating, your tubes are perfect, why am I not conceiving? I can't answer it, unfortunately.
It is hard.
Yeah.
Wow. It's like going to the hospital and then you are told everything, the tests are negative.
Yeah. And you're feeling bad.
Are feeling bad.
Yeah.
You are so unwell. So you wonder, maybe the labs, the machines are not really working.
Yeah. But I think there are some things beyond our comprehension and our control. And that's why a lot of people also turn to herbal medicines. So a lot of my patients are on. I think the most popular one now that I'm hearing everywhere is arrowroot. I don't know if you've heard of it. There's a lady called, a company called Harriet's Botanicals that does arrowroot. So it's like a liquid, herbal liquid.
Like the forever product.
I don't know the forever. So this one is specifically for women's health, like menstrual disturbances, painful periods, fibroids, cysts. I don't know what it has because my training is like Western or classical medicine.
Yeah.
So even when patients ask me, can I use this herbal? I would say, I don't know. Because I don't know what it has. I don't know what the side effects will be for you.
Yeah.
I don't know whether it works, so I can't recommend it because probably I don't have enough. But I'm sure, like all the medicines that we use, they come from plant-based products. But I don't have that training.
Yes.
I'm not a herbalist. I've not done Chinese medicine, so I can't recommend it. But I can say many patients here come and tell me their own herbals. And for some people, they swear by it. They have painful periods, they're on these herbals. The periods are now, they're enjoying life once again.
Okay.
So I can't say it doesn't work. I would say it seems to work for some patients, but I don't know how it's working.
Yeah.
Yes.
And the painful periods. Why do some have so much painful periods and others it's like you don't even know that you have periods?
God's chosen few.
Yes.
I think we have been cultured and brought up to believe that painful periods are normal. But now the current generation of doctors telling patients pain is not normal.
Yes.
Pain that you curled up in bed 5 days of the month, you can't go to work, you can't be intimate, you can't work out, you can't go for a social outing because you're in severe pain. That's not normal. Yeah. So if you have severe pain, then we need to look for an underlying cause. So stuff like fibroids, cysts, commonly things like endometriosis, adenomyosis, infections. There's so many things that can cause pelvic pain. So if you're in a lot of pain, you're not functioning, it's affecting your quality of life, you need to see a doctor. You need to see a doctor for investigation. It's not normal.
This is not normal.
It's not normal. We should now move away from that mindset of pain. Lazima ujikaze. You can't just jikaza for the rest of your life.
I know.
Yeah.
And some even say when you give birth, the pain go, but some don't. It doesn't go. So if you give birth and the pain, they're still reoccurring.
Yeah.
What should be the issue?
It needs investigations. So what we tend to do is first we take a history. So we take your whole medical history, your obstetric, your gynae history, your drug history, everything. And then after that, then we examine you. So we examine your tummy and we do an internal exam as well to examine your cervix, to examine your womb as well. And then we do a scan. So with those range of things like the history, the physical examination, and the scan, we're able to pick up most of the problems. Yeah, very, very rarely we'll send you for stuff like MRI, but mostly from just those three things, just in this space, because we can scan you here, we can talk to you here, we can examine you there. We can pick up most of the problems. Yeah.
Wow.
So the advice is see your gynecologist.
Yes.
Yeah, don't suffer in silence.
Yeah. Even those who have infections like UTIs and maybe they are reoccurring. They should also see a gynecologist.
There is treatments, there is investigations and treatments for recurrent so UTIs like urine infections or vaginal infections like bacterial vaginosis, candidiasis, stuff like that. There is effective treatments for them. Yeah, so some people have discharge all the time, offensive discharge. Some people have, like before your period, you have, after your period maybe you have infections every month. You're taking antibiotics and you're putting pessaries every single month. And then people do it over the counter as well.
Yes.
So they know, like, if I'm itching a bit and have this creamy discharge, I know it's yeast infection. I'll just go to the counter, I get pessaries. But then you're doing that every month. That's not normal. So if you're getting recurrent infections, see your gynecologist. They'll do specialized testing and they'll put you on, we call it suppressive therapy or long-term therapy. So like some medication you just take for a few days every month, maybe for 6 months, and that tries to get rid of the recurrence.
Can they become chronic?
Yes. So you can have chronic. So the definition of chronic is anything that's been there for more than 2 weeks. So if you've had abnormal discharge for 2 weeks, that's a chronic discharge or a chronic infection. Yeah, and that can lead to problems with fertility, as we discussed. Can affect your tubes, can affect your womb, and if you're having infections all the time, then affects your regularity and confidence with baby making. So it's multifactorial.
And for those who have been removed fibroids and are not being able to conceive, what can you tell them as like what can they do? Because sometimes even the fibroids reoccur.
Yes. So typically with infertility can be multifactorial. So you can have, even if you just remove the fibroids, it could be that there's another cause. Maybe your tubes are blocked as well. Maybe your partner's sperm count is low. Maybe your ovaries are not functioning well. So if we thought that your infertility is caused by your fibroids, and you remove the fibroid and you're still not able to conceive, then you need to do testing for other causes of infertility. Yeah.
Wow.
Class is in session.
I know. Wow. Okay. I'm speechless. There's a lot to learn.
There's a lot to unpack. I think even when we spoke earlier, we said like you wanted to do several topics. I said each of those topics can speak for a whole day. Because women's health is, we're passionate about women's health, and we have done lots of studying on it. So we have lots of knowledge on it as well. So we can talk about a topic for, and we know it affects people so much. We see it every day here in the clinic. So I believe that's what I'm doing, like trying to do a lot of education on social media, trying to give people who maybe can't afford to come here but they're suffering with a problem, or at least the knowledge that, okay, fine, that's what I'm having, I think that's what I have, and this is the recommendation.
Yes.
And a lot of people send me messages on social media as well. Sometimes, like, my relatives would say, why are you giving free consultation, you know? But some people can't afford it.
Yeah,
And
true.
it costs me nothing to reply a message.
Mhm.
Like, in fact, my Instagram DM, my direct messages box, is like an extension of my WhatsApp. Like, I check it as often as I check my WhatsApp. Because there's somebody maybe who's suffering.
Yes.
And they've just said, let me try, just send a message to this guy.
See if I can
They're not expecting a reply, but when they get a reply, they say, oh, thank you so much for replying. It really helped me, I was suffering.
Mhm.
It's so small things. Not everything has to be financial.
About money.
Yeah. It's just also impact on life, however small.
Yes.
Yeah.
That is good.
Yeah.
So, what are you telling my audience?
I'm telling your audience that we do our best as doctors to take care of you, but we know we can't do it alone.
Yes.
So whichever higher power that you ascribe to,
Yes.
because of course, my patients are from all walks of life.
Yeah.
We work in combination with higher powers and with you as well as the patient.
Yeah.
So I would say, don't only use one avenue.
Yeah.
So you have your faith, and that faith can move mountains.
Yes.
But you also have qualified doctors who can help you on this journey, and you also have yourself.
Yeah.
You have a big role to play in your own health. So that's what I'll say. If you have a problem, a question, a concern, just see a doctor.
Yeah.
Just see a doctor. We'll have a chat and we'll chat a path
And
for
not
you.
to give up.
Not to give up. That's why you
Yeah.
see, I started by saying we're moving away from infertility with its finality
Yes.
to subfertility, meaning that maybe for this 1 year you've not been able to conceive, but we can't predict for 2 years from now, or
Yes.
5 years from now, 10 years from now.
Yeah.
We have people we have antenatal patients here of 52.
Wow.
So it's not impossible.
Normal conception.
No, idea. For normal, we have
But they're
people in
also
their
normal.
40s. Yeah.
Yeah.
So for spontaneous conception, we have people in their 40s. But yeah, 50s would have to be IVF. But still, they're carrying a pregnancy,
Yeah.
and they'll have a baby, and
Mm.
they'll have their mother with journey.
Yes.
Mm.
Awesome.
Yeah.
So, if someone wants to reach you, you said you are on Instagram.
Yeah.
What is the number that someone can reach you?
Yeah.
Because I know there are some people who might not be in Nairobi
Yes.
and maybe looking for your assistance.
Yeah.
Yeah. So, can you give your contact? And
So,
for those who are in Nairobi,
Yeah.
the office
Where they can find us. So we at Gilead Women's Center, which is at NSSF building on Bishop Road. Don't be confused, there's a lot of NSSFs. We have a lot of patients going to Haile Selassie. So Bishop Road near Community in Upper Hill. Block A, floor B1, it's called Gilead Women's Center. Or if you ask Dr. Obwaka's clinic, then the guards will show you down. You can reach me on my Instagram, is on I'm most active. My handle is Dottore, DOTTORE_1. And in terms of contacting me on email as well, you can send me an email on chris@gileadmedical.com, or you can send me a message or call me on 0727 093 393. So those are all my avenues for. We try to reduce the barriers to access. So I typically say I don't have a lot of bureaucracy.
Okay.
If you want to book an appointment, call me, I'll book you in.
Oh.
Not go talk to my PA, talk to my secretaries.
I know.
Yeah, for the younger doctors, I think we are much more accessible,
Yes.
and I think that reduces the barriers to access.
Yeah.
Yeah. If you have an emergency, you want to know that I can call my doctor
Anytime.
and I'll get him
Yes.
anytime.
Anytime.
So that
That's
sense of
true.
security. Yeah.
Yeah.
Mm.
All right. Thank
Yeah.
you so much.
Thanks,
This
Anna.
was a nice discussion,
Yeah, very
and
nice.
I believe the audience are going to get something
Yeah.
from it.
Yeah.
Yes, just as you have heard, as we continue this series of the weight, the pain, and the healing, just see the doctor. If you have any issue, if you have any sicknesses, I think we all need a gyna in our life for the ladies and maybe a urologist for the men. Yeah, so thank you for having Daktari and I, and his contacts and everything is on the page, so you can just get in touch with him whenever you have a problem, whenever you have a question. He's free. He's ready to receive calls. Don't just book from the secretary or the office. You can just get him directly. So thank you for tuning in again, and see you next time. Please remember to subscribe, like, share, and comment. Thank you.